Okay, I can't see anybody, so if there are any comments or questions as I'm walking through this, please feel free to just speak up. But thank you for that introduction. I guess you want everyone to wait.
To
Yeah.
the end.
Okay.
Yes. Thank you.
Okay, just kidding. Just wait. So thank you for that introduction, Rachel. And I am here to talk about peer recovery doulas, which is a frontline support for perinatal substance use disorder and a workforce that we are developing in South Carolina. Okay, let's move these slides. I have nothing to disclose, and I'm going to start just with a little bit of background information. I feel like a lot of people in this room already know this stuff, so I'm not going to dig deep into it. But maternal mental health and substance use disorders are the most common complication of pregnancy and childbirth. Close to 1 in 5 women will suffer with a mental health complication, and that's just the people that we know about. It's underreported, undertreated. It's also the most frequent underlying cause of pregnancy-related death, so close to 22.7%. This was in 2019. That may have changed since then. Were reported to be contributed to mental health conditions, and that was coming from the maternal mortality review committees across 36 states, including South Carolina. And if we dig a little bit deeper into that number, you can see that those deaths were attributed to a combination of suicide, homicide, and drug overdose, mostly driven by drug-related deaths. Many of those drug-related deaths are, of no surprise, contributed to fentanyl and other synthetics or opioid use. And we also know that the year following delivery is a really vulnerable period with the highest rate of overdose mortality occurring in the late postpartum period. So, roughly 6 to 9 months, really deep into that year after delivery. The good news is, I always start with this kind of depressing information, but the good news is a really high percentage of those deaths are determined to be preventable. There's some that say up to 100% of them are preventable, and they're preventable with better screening, identification of perinatal mental health and substance use disorders, and ensuring access to comprehensive evidence-based treatment and recovery services such as care coordination, medications for opioid use disorder, and wraparound services that address the psychosocial needs of women and the mother-infant dyad. However, only about 25% of pregnant women with perinatal opioid use disorder and just the greater substance use disorder category receive treatment, and among them, among women who initiate the medication for opioid use disorder, only about 56% discontinue that medication by 6 months postpartum, significantly increasing their risk for relapse and overdose. And as I just mentioned, that's that really vulnerable period. So, what's leading to this? What are these huge barriers that are keeping people out of treatment? The first of which is access to treatment across our state's 46 counties. HRSA has designated that 30 or 43 of our 46 counties are completely or partially medically underserved, and South Carolina ranks as 49 out of 50 in access to mental health care. We know that rural patients often lack private or public transportation. They have minimal childcare options, but at the same time are required to travel great distances for care. The really high rates of poverty in South Carolina result in unaddressed social drivers of health and inadequate health insurance. And South Carolina's really long history of racism and discrimination creates significant structural determinants of health. Birthing persons with substance use disorders are also really highly stigmatized in society and in healthcare, and even within our recovery communities, especially if they're utilizing medication for opioid use disorder as their recovery pathway. And as a result, they often avoid healthcare systems in general, including prenatal care and recovery support services, due to this very real fear of legal and social consequences. And they may not disclose substance use in fear of a punitive response from the healthcare system. So, altogether, this population has some unique challenges, but pregnancy is this really incredible window of opportunity to find recovery because, like the general population, birthing parents are really highly motivated towards positive health change to support their baby. So, our job is really to meet them with motivation, meet that specific motivation with compassion and non-judgment. And one of the interventions that has been impactful in other marginalized communities, particularly those that are underserved by our current health and social service systems is doula support. So there are many types of doulas out there. There are specialties within different doula pieces or phases of the perinatal period. But the type of doula that I'm going to focus on today is a community-based doula. And this is a really special type of training that I love because a community-based doula is somebody who is trained and or apprenticed. So a lot of times community birth workers can be people who have come into generations of birth work, and they provide non-clinical, emotional, physical, and emotional support before, so during that perinatal period, during and after birth, and during and after labor and delivery, and then into the postpartum period, often up to a year, maybe longer into the postpartum period. And what's really special about community-based doulas is they are really well versed in the community that they serve. The model that they utilize is rooted in shared lived experience. And so there are community-based doulas who are deaf and disabled, and they serve deaf and disabled mothers, or they had a teen pregnancy and they're serving young mothers. So they're able to bring their shared lived experience and this level of mutual understanding into the individually tailored and advocacy model that they use, which is really an incredible way to build trust. They attend a minimum of one prenatal medical provider appointment, but often they are much more involved than that. They're with, like I said, their clients the majority of the prenatal period. They provide hands-on support during labor and delivery, and then they support in the postpartum with newborn care, with resource referrals, with parenting support, really anything that spans that year period. What's really also important about a community-based doula is they are very involved in ensuring that barriers are removed so that their clients can receive postnatal care or attend their postnatal appointments. So figuring out what resources are necessary to get that transportation or to bring people to their home. And they really provide continuity of care across the perinatal period. So they are walking with their clients for almost 2 years as their providers change, as their system might change. There's a lot of things that happen through pregnancy, birth, and postpartum that shift and are difficult to navigate, but this person is walking alongside. And so there's a good amount of research out there at this point that supports community doula support, and it just shows that there's an improved access to care. They help to mitigate perceived and actual stigma and bias from healthcare professionals, which we know is a big one for perinatal substance use disorder population. They help empower birthing persons, foster greater sense of self-esteem and self-efficacy, improve healthcare literacy, reduce healthcare costs, that's another important one, increase rates of breastfeeding, and lower the risk of a number of birth outcomes that we're not looking for. I do want to just mention that while that seems incredible, doulas and community doulas specifically are not a catch-all answer for everything. They are super helpful when they're used in in a healthcare system that has other levers to pull, but they can't, obviously, I'm sure this audience is aware of that, fix everything. Now, when it comes to doula support for the perinatal OUD population, there is a group that is up in Philadelphia that has done quite a bit of work looking at what happens when we bring a doula onto a treatment team. And the research that they've published has shown that, and this group is led by Megan Gannon, and they're up in the Philadelphia Department of Public Health, I believe. And they have shown that when a doula is on the treatment team for somebody who is struggling with a substance use disorder, that person reports increased emotional support, increased self-advocacy. They attend more prenatal care appointments. They show increased health literacy, and they report a decreased perception of stigma. They've also shown that into that postpartum period, parents with opioid use disorder specifically who engage with peer support specialists demonstrate a greater retention and engagement in healthcare services and report improved relationships with healthcare providers, including increased trusting relationships, which is awesome. Um, Actually, one of the things that I wanted to mention about the data that Megan Gannon has published is they often recommend that while doula support is really helpful, that including lived experience of perinatal a perinatal substance use disorder into that doula support or into the peer support specialist support is going to be crucial for keeping these mothers engaged. And that really maps right on with some of the research that I've done in the past, which, if anybody is familiar with some of the work we do at WRBH, one of the patterns that we typically have is we'll create an intervention, we'll do some qualitative work and get some feedback. And then a lot of times we'll have to change the intervention because it wasn't what the population was looking for. And that's exactly what happened here. I had a web-based intervention that included peer support specialists to support mothers in recovery. And the feedback that I got is, yes, this is great. We like peer support, but we really want other mothers in recovery. And specifically, some of the things that they said were, when somebody is there that not only supports you, but knows what you've been through, it's a game changer. And another mother mentioned, I feel embarrassed talking about my pregnancy. I only like talking to people that have been there and done that because I feel like when they're encouraging me, hey, I was doing the same thing. I dealt with the same thing. I went through the same thing, and here I am. I got through it. I think it helps, and I know that they aren't judging me. So that's a huge piece, that trusted, authentic relationship built on shared understanding. So we went back to the drawing board and we decided to create a specialized maternal workforce in South Carolina, which is a peer recovery doula. And this is under the program ReBIRTHed. I'm the director. It's housed within WRBH. We have been working since 2022. And a peer recovery doula is somebody who has that lived experience of perinatal substance use disorder and/or recovery during pregnancy and postpartum, is trained as a peer support specialist to assist with recovery, and then also has that added layer of certification as a community-based doula to provide the prenatal, labor, birth support, and postpartum support. So I'm going to fly through these next two slides just for time. That's just talking a little bit about what kind of training they go through. But in a series of synchronistic events, I got linked up with Molly Chappell McPhail, who is with Birth Matters, which is an incredible nonprofit organization up in the Spartanburg area that provides direct community doula services in Spartanburg and Cherokee County. And they have been training community doulas for upwards of 10 years. So they are really well established and know what they're doing. And we worked together to create a curriculum specifically for this workforce. And so that includes 55 hours of group-based facilitation, group-based didactic education. It's usually delivered over 8 to 10 weeks, depending on scheduling. It's in a hybrid model that really helps our busy moms. So they have some virtual information and then some really intense in-person hands-on learning. And then we included a lot of topics that are really helpful for this population. And that includes some pretty intensive information on perinatal mental health, on substance use disorders, justice involvement, how to move through the system, things like that. After they finish that didactic portion, they then move on to certification. So they take that information they learned and they go to observe. And that requires 2 prenatal appointments, childbirth and education classes, breastfeeding classes. They attend 2 labors and birth and 2 postpartum observations. So really the things they'd be walking through with their clients. And then to become endorsed by our program, by the ReBIRTHed program, we require them to participate in mentorship for up to 18 months, sometimes a little bit longer into the 2-year range, where they're receiving one-to-one support, as well as weekly group support. And they are required to provide support to a minimum of 2 families that are affected by substance use disorder across the full spectrum. So they're with those families for, sometimes close to 18 months, a little bit longer than that. So they really get a lot of training. And then I just have two more slides. While we are mainly focused on training and mentorship and helping people get prepared to provide peer recovery doula services, we do have direct services available at WRBH through the Moms Impact program. We have a full-time doula on staff. Her name is Cheryl. She's in this meeting. And we have been running a pilot to look at the effectiveness of having a peer recovery doula on a care team. And so we got this pilot really up and running late October, beginning of November of last year. Cheryl is offering full spectrum doula services, and she is in the PD region. So has an up to 2 hour radius where she'll provide support. So we've been able to hit a lot of those really rural counties up in the PD, as well as Horry County and Georgetown County, and Charleston as well. And we are collecting a number of outcomes. Today, I'm going to share with you some preliminary birth outcomes, but we also have some longitudinal information coming through that's looking at the potential reduction in mental health symptoms and substance use, social connectedness scores, maternal functioning, self-efficacy, attendance to treatment throughout the entire period they're with us, and treatment retention. And the Cheryl has a larger caseload than 9 participants, but a lot of the people that come to us looking for services are beyond 25 weeks gestation, which is what we were required to enroll in this pilot. So she does do quite a bit of hands-on support at births, and we have some other trainees that are doing that, as well as people who are providing postpartum services. So to just quickly look at our preliminary outcomes, and some of these I'm quite proud of, we've had, of the 9 enrolled, we have birth outcomes for 7 participants. 2 have not given birth yet. But our average weeks gestation is 38.2. Our average infant birth weight is 7 pounds, 4 ounces. So we're having some healthy babies. Mode of delivery is about 57% vaginal and 43% cesarean. We have had no extended NICU stays. 100%, so 7 out of 7 of those participants have initiated breastfeeding. All 7 of them that have had DSS cases were closed, and they have all attended their postpartum appointment. They have all retained in treatment, so they're continuing to go to therapy and their medication management, anything else that they're working on. And all 7 have maintained recovery. And some of them did not start out in recovery. They came to us really struggling, and they're all, doing well with baby and healthy. So just to end and leave you on the note that I would like you to think about, why are peer recovery doulas so important? And the reason that I think that they're really, really important for this population is they serve as an anchor in a sea of chaos. Many of these women are coming into recovery, sometimes for the first time as they're stepping into motherhood, and there is a lot going on. These are huge transitions, and they have somebody with them walking side by side the entire time. And having that person that they can turn to when everything is chaos can be absolutely life-changing. And then the second deeply important thing is that we train our peer recovery doulas to help their clients build personal power and promote self-advocacy. So these doulas are not standing up in front and telling what needs to be done. They are helping these women who potentially lost their voice in active recovery reclaim that voice, learn that they have choice, and build autonomy through participation and collaboration with their healthcare team and with their family. And they bring those skills after their doula has left them into their family as they move forward, to really develop more trusting relationships, more self-trust, and healthier families. So with that, I will go to